Mutational testing is a very important part of the initial diagnostic workup for new acute myeloid leukemia patients today. The way I like to think about the mutational testing is it depends on what the backbone of therapy is going to be. So if we're going to use high-dose induction therapies, cytarabine, anthracycline based, then chromosome and mutational testing is extremely critical. If the patient has an FLT3 or FLT3 mutation, then we would add a drug called midostaurin, which is a FLT3 inhibitor, to the 3+7, and this is shown in phase 3 studies to improve survival and response rate and is quite well tolerable. On the other hand, if the patient has a core binding factor chromosome change, inversion 16, 821 chromosome alterations, then we would add gemtuzumab, an antibody drug conjugate, to the backbone of 3+7, also can improve the overall survival 20% or so in that core binding factor population. And then if the patient has an IDH1 or 2, there are trials looking at adding IDH inhibitors with some early promising data. And if a patient has what we call secondary AML or MDS-associated cytogenetic changes, then there's a drug called Vyxeos or CPX351 that is approved in this indication and has shown improved survival. So there's 4 different treatments that you could give to a young patient with induction therapy, either adding a drug or using an alternate drug, all of which have shown superiority to standard 7+3. So mutational chromosome testing is quite critical because you want to give the patient the best chance by selecting the appropriate regimen. Now in older AML, the mutational testing is also important, but not as critical to selecting the therapy. So it still plays an important prognostic role. So patients who have NPM1, IDH1 and 2 mutations, core binding factor in general tend to do much better. And those who have adverse mutations such as TP53, ASXL1, FLT3, they tend to do worse. However, therapeutically, we don't have the degree of segregation of treatments like in younger AML. So for most older AML patients, if we decide that they're not good candidates for high-dose induction, like this patient because of comorbidities or organ dysfunction or age, then usually starting off with a hypomethylating agent with venetoclax, either azacitidine or decitabine, or lodocytarabine with venetoclax, is quite reasonable. There will be data shown at the American Society of Hematology meeting in 2019 and published in the near future, showing that the response rates across different mutational groups with hypomethylating agent and venetoclax are actually quite well maintained, between 50 to 75%. Now, survival-wise, the people who have high-risk mutations, TP53, FLT3, they do have a poorer survival, but it is still better than azacitidine or decitabine alone. So I think in the community, it's reasonable to send the molecular testing, rush it if you can, but if you have decided that this patient should not get cytarabine anthracycline induction therapy, I don't think it would be wrong to start the azacitidine with venetoclax or decitabine with venetoclax, and then use the mutational testing to either fine-tune or consider other therapies in the relapse setting.